Alright, as promised, let's discuss toxoplasmosis today, the most common cause of posterior uveitis across the world. A little bit of the microbiology part. Personally, I never enjoyed remembering microbiology, honestly, because there was too much to remember. But when you're trying to integrate subjects and when you're trying to have a clinical suspicion of toxoplasmosis, when you see a patient with clinical features suggestive of the same, that is where microbiology comes into play. So the organism is Toxoplasma gondii, an obligate intracellular parasite. The active form is called tachyzoid and the latent form is known as the bradyzoid. So how does it enter the host? It doesn't matter whether it is the intermediate host or the definitive host. So the definitive host is cat, the feline species for Toxoplasma, and the intermediate host can be anything else. It can be human, can be mice. So it enters the host by ingesting an intermediate host. So how does this happen? Either an uncooked or a non-cooked meat, which may happen in case of animal consumption, a cat consuming some other intermediate host, or in case of humans, it can be more likely to be ingesting a sporulated oocyst. So what is a sporulated oocyst? It is basically one of the forms of Toxoplasma gondii, which is found in soil, in water, or vegetables. So as you can see, it's very easy for the parasite to enter the human body. Certain rarer modes of transmission, such as transplacental and organ transplantation, not as common. More important are the ingesting or the gastrointestinal tract pathway. A little more about the sporulated oocyst. So this is shed from the feline feces about 3 to 18 days after the cat itself gets infected, and it can persist in the soil for up to 18 months. Millions of oocysts can be excreted in one single day. I'm sorry, excreted is not the correct word. Just removed via the feces every single day, and it can persist in the soil for up to 18 months. So it's a very long time to infect other animals. Once the tachyzoid enters the host, it immediately converts into the bradyzoid, and that is because the immune system starts attacking this active form. It is more difficult to attack the latent form because it is forming a cyst. It is forming a covering around it, so the immune system cannot attack it, and that is why the tachyzoid immediately converts into a bradyzoid as soon as it enters the host. This bradyzoid is a dormant structure. It doesn't show any much metabolic activity, so it becomes difficult for the body to target it. It forms cysts because again it forms a covering around it, so the immune system again cannot attack it. It evades the immune system, and it also evades the drug therapy that you give. So bradyzoid is almost impossible to eradicate. You can only remove the tachyzoid form from the body by giving medications. It is very difficult to remove the bradyzoid because even the drug cannot penetrate through the cyst. It usually goes and deposits into the striated muscle and forms cysts over there. And if not the striated muscle, the next common location is the central nervous system. Even within the central nervous system, since this is an ophthalmology topic, it will go and deposit in the neurosensory layer of the retina. It shows a very high degree of genetic recombination, and this is because the organism can reproduce sexually as well as asexually. So the sexual reproduction part is what produces this genetic recombination, and there is a very high potential for this organism to become even more virulent with each genetic recombination. If the cyst ruptures, the bradyzoids release, and once these released bradyzoids enter the circulation or enter the surrounding structures, for example in the eye, it will enter the vitreous and the retina. It converts immediately to a tachyzoid, the active form, and that reactivates the disease. This is what makes it difficult to treat toxoplasmosis, and that is why treatment is to be prolonged. It cannot be done over a period of couple of weeks. It needs to be prolonged, sometimes as long as a period of 1 year. So as you can see in the image, that is the retina. So the retina is sort of distorted. It is not looking like a normal retina. You can see some of the more bright pink cysts, which are the toxoplasmosis cysts. You can see the RPE has been disturbed, the retinal pigment epithelium. The Brooks membrane is disturbed, and some amount of choroidal disturbance is also seen. Top right corner, the bluish image is a Gomori methanamine silver stain, and the toxoplasma cyst stains positive with the help of this stain. 1/3 of the world population at any given time is affected by toxoplasmosis. Does that mean 1/3 of the world population will show symptoms? No. It just means that 1/3 of the world has toxoplasmosis in their body. It doesn't mean that there is clinical features, that it doesn't mean that the patient is going to be symptomatic. It just means that the organism is so widely prevalent in the world that any point of time, 1/3 of the world's population has the organism in the body. So it's a highly prevalent organism. Antibodies are seen in almost 80% of the population of France and South America as a whole, and this is because the immune system is pretty good while tackling Toxoplasma. This has been a very old organism. It has been attacking humans for ages, and consequently the immune system has also adapted very well to this organism. Coming to transplacental transmission, as the trimester progresses from first to third, the risk of transmission of the infection increases, but the severity decreases. And this makes sense because the longer the trimester progresses, there is a higher chance of the organism getting transmitted from the mother to the fetus via the placenta. But as the fetus is maturing, its immune system is also developing and becoming even better. So the severity of the infection is going to reduce. So say for example, in the first trimester, toxoplasmosis occurs in a fetus, fetal death, intrauterine fetal death can also occur. Whereas the third trimester may not be as severe. There may only be subtle changes such as only chorioretinal scarring that you might get. And ocular involvement is seen in a variable cases. Just because you have toxoplasmosis in your systemic circulation doesn't mean that you will be affected in the eye as well. Ocular involvement happens only in 2 to 20% of the people affected by toxoplasma. So only 1 in 5 at the most patients of toxoplasma will show ocular features. And this is more common in case of a congenital toxoplasmosis. As much as 80% of children with congenital toxoplasmosis will show ocular features. And that is because the immune system is not as mature as in case of an adult. So what exactly goes wrong when toxoplasma enters the body? 2 simple words: hypersensitivity and autoimmune response. It's actually 4 words, but hypersensitivity and autoimmune response are at the basis of the pathology to toxoplasmosis. What goes wrong in the eye? There is focal retinochoroiditis. Why do I call it focal? Because only certain areas of the retina are affected at a particular point of time. The entire retina or diffuse retinal involvement does not happen. And why retinochoroiditis? It means the retina is more predominantly affected compared to the choroid. The retinal neurosensory layer is where the cysts are depositing, because of which the retina gets affected earlier and to a greater severity compared to the choroid. Hence, it is called a retinochoroiditis. The problem happens when necrosis happens, because the organism is going to produce trauma to the normal tissue around, as well as the immune system, which is trying to destroy this organism. So there is going to be a necrotizing granulomatous inflammation at 4 structures in the eye. The retina is going to be involved, the choroid, the vitreous is continuous with the retina, hence there is also going to be vitritis, and sometimes the anterior uvea, which is the iris and the ciliary body, are also affected because again they are one continuous structure. Think of pathogenesis of uveitis. I'll leave a link at the top of description, at the top of video, to just brush up the pathology of the uveitis part. So anterior uvea can also be involved because it is one continuous structure with the choroid behind. Sometimes free parasites can also be seen, more commonly in the necrotic region and less commonly in the normal retina that is surrounding it. If it is a cyst form, a bradyzoid form, then it is likely that immune reaction will not be incited. There is inflammation is not going to happen, and intact cysts may be seen in the retina. And the most common way that this disease resolves is by scarring. There is a lot of scarring that happens. The organism itself produces scarring and the immune system adds to the insult. So scarring happens after the inflammation starts subsiding. So there are 2 things that go wrong. There is the host immunity and the parasite virulence that determine how bad is the inflammation going to be. So coming to host immunity, congenital cases happen more often than adult cases because immunoimmaturity is the cause. So the immune system is immature, you are going to have more incidence of congenital toxoplasmosis, and in adults, immunocompromise puts you at a higher risk. Say for example, it is a patient of acquired immunodeficiency syndrome, or the patient is undergoing organ transplantation or has already undergone organ transplantation, is on certain immunosuppressants, for example azithromycin, or if the patient is on systemic steroids for a very long duration for some other condition. So all those factors come into play, and you can have an increased incidence not only of ocular features but also systemic features. In fact, in toxoplasmosis, you have more of systemic presentation than ocular. The ocular part comes later. It is first the systemic circulation that gets affected first. Parasite virulence, there are 3 kinds of parasites that are yet detected. There is 1, 2 and 3. 1 is the most virulent. It is going to produce the most amount of inflammation, most scarring in the retina. Type 2 is the least virulent, and that is going to, and that is because it forms a cyst. It doesn't actively proliferate as much, it becomes a cyst and it goes into the dormant stage very quickly. So that makes stage 2 less virulent as compared to the other types. So once host immunity and parasite virulence come into play, there is retinal seeding by the cyst, more specifically in the neurosensory layer of the retina. Once this cyst ruptures, there is going to be release of bradyzoids. These bradyzoids will convert to tachyzoids, and local recurrences will keep occurring in the retina. So that is what produces so much problem in the visual pathway. So what immune defenses does the body offer to toxoplasmosis? First and foremost, because it is the gastrointestinal system, which is the most common site of entry, the GI enterocyte barrier provides the first line of defense. If that fails and if the enterocytes get infected, then there is the innate immune response, which constitutes of polymorphonuclear lymphocytes, macrophages, and more importantly, the natural killer cells. If the innate system fails or is unable to, sort of take care of the organism completely, then that is when the adaptive immune response comes in, which constitutes most importantly of the CD4 plus T lymphocytes. Along with that, inflammatory markers are also released, such as interleukin 12, interferon gamma, and TNF alpha. So some of the commonest inflammatory markers that you see, those are starting to get starting to appear as a part of adaptive response. What clinical features will the patient present with? So understand here that before ocular, this toxoplasmosis is affecting the system as a whole, the human body as a whole. So systemic features are going to be more common compared to ocular, and they are going to present earlier than ocular features. So what systemic features am I talking about? Fever, malaise, or lymphadenopathy. And in early stages, it appears like this patient has an infectious mononucleosis-like condition. So that is why these first three symptoms are also called mononucleosis-like features. The other conditions that you can see are pneumonitis, hepatitis, myocarditis, and encephalitis. So that is basically wherever these cysts are forming, wherever this organism is causing an inflammatory reaction. So clinical features are going to be according to where the cyst is seen. Now coming to ocular features, this may develop years after postnatal infection. So the first, foremost, and the most important ocular feature that you see is retinochoroiditis. This is nothing but an exudation at the posterior pole. You can see the white, fluffy, cotton-like lesion at the posterior, on the retina. This lesion is not at the posterior pole. When I say posterior pole, I mean closer to the macula. This is a more peripherally placed lesion. So a little atypical presentation that you can see. Satellite lesions are very common. This is very similar to fungal, ulcers of the cornea, if you remember. Satellite lesions basically mean a main primary lesion at the center and small lesions surrounding this lesion. And full thickness involvement of the retina and the choroid occurs, following which the vitreous also starts getting involved. The next lesion, vitritis. So vitritis basically means now the vitreous is also undergoing inflammation. There is a dense cellular infiltrate, and because there is inflammation in the vitreous loses its transparent appearance. It becomes hazy. And when you see the retinochoroiditis through such a vitritis, it gives you a headlight in fog appearance. So the headlight in fog, the headlight that you see is actually the retinal lesion, and the fog is because of the vitritis. So that is why it appears as though you're looking at a headlight from a fog. One of the most classical features in ophthalmology. For some reason, almost every student of undergraduation is able to catch this lesion and identify it correctly. And this vitritis will be absent if only the outer retina is affected, which means now I'm talking about the neurosensory layer, which is closer to the vitreous. But if only the outer layers start getting affected, then I'm less likely to have vitritis. I will more likely have a serous retinal detachment. The next clinical sign that you can see is a perivascular sheathing, because it is also the blood vessels that are undergoing inflammation. If you're a basketball fan, you will appreciate the blue colored word, chiralisis arteriolitis. It is just another word for perivascular sheathing. And venular occlusions can occur if the inflammation is severe enough. The other features, macular or optic nerve edema because of a generalized inflammation. Some spillover anterior uveitis, because again it is one continuous structure. The posterior uveitis can progress to form intermediate and continue to become anterior uveitis. So spillover. And raised intraocular pressure, simply because there is so much inflammation going on. There are n number of reasons why you can have an increased intraocular pressure. Lastly, you can have scarring. So almost every case of toxoplasmosis will end with scarring. This scarring is because of a pigmentation, and this pigmentation is due to a retinal pigment epithelium. So the pigment, the melanin pigment present in the RPE, that undergoes hyperplasia or hypertrophy. So any old lesion of toxoplasmosis will almost always show scarring with pigmentation. So the left image that I want to show you, look at the green arrow please. The green arrow does not show any blackening, bluntly speaking, around the lesion. So that is a fresh toxoplasmosis lesion. Just next to that, look at the red arrow. That is, there is a cuff of pigmentation around the lesion. So this is an older lesion. So this new lesion, the green arrow, which is just next to the red lesion or the red arrow, that is called a satellite lesion. So these satellite lesions are very often stuck to the older lesions. Right-sided image, this is a typical wagon wheel scarring at the macula. Shows a very bad visual prognosis and more common if it is a case of congenital toxoplasmosis. So a little bit of congenital toxoplasmosis. A classical tetrad called Sabin's tetrad is seen. So that constitutes four things. It constitutes cephalus, which means hydrocephalus or microcephaly, calcifications or intracranial calcifications, because these cysts start showing deposition of calcium. So there is intracranial calcification on an X-ray or a CT scan, convulsions and other intellectual disabilities, and finally chorioretinitis. It is actually retinochoroiditis, but just to keep the alliteration of C. So 4 C's: cephaly, calcification, convulsions, and chorioretinitis. So that constitutes a Sabin's tetrad. Not always seen. All 4 features may not be seen in a patient, but just as a mnemonic, I thought I should share this with you. The diagnosis of toxoplasmosis is mostly clinical. There is absolutely no substitution for thorough history and examination. But serological tests can be done as a supportive measure. So if you see IgG, it is more indicative of a chronic infection. IgM denotes a more recent infection. If IgG and IgM are negative, it excludes toxoplasmosis as the cause. But if they are present, they need to be present in significant titers, because remember, 1/3 of the world population is affected by toxoplasmosis at any time without all of them showing symptoms. So just presence of antibodies does not mean that this patient has clinical toxoplasmosis right now. It may even be an asymptomatic, just a presence or a past infection. So these need to be in significant titers. The titers vary according to age, according to the gender, according to the geographical location. But just understand that simply presence of antibodies to toxoplasma doesn't mean that this patient is currently infected with toxoplasmosis. If the IgG persists more than 1 year, or if IgA is seen, this is highly suggestive of a congenital toxoplasmosis. Certain microbiology tests, I thought I should just share the names with you. There is Sabin-Feldman's dye test. So 2 Sabins in toxoplasmosis. One is Sabin's tetrad and one is Sabin-Feldman's dye test. I don't know if they are the same person. Just remember the name, please. There is complement fixation test and there is indirect hemagglutination test. A newer modality of diagnosis, which is even more sensitive and specific, is PCR of the ocular fluid. So PCR is polymerase chain reaction, and under polymerase chain reaction, a very specific indicator called the Goldman-Whitmer coefficient is utilized. So this Goldman-Whitmer coefficient is basically a ratio between the antibody and the globulin levels in the same fluid. So I compare the antibodies to toxoplasma as well as the globulin levels, and if I find that the ratio is high, which means more than, I do not know the exact value, but if it is higher than normal, it means that there is an infection with toxoplasmosis. Whereas if the ratio is lower, which means there is more globulin than the antibody produced, that means antibodies are not as much produced. So this is less likely to be toxoplasmosis infection. Treatment is not always required. Again, remember, 1/3 of the world's population is affected by toxoplasmosis. So if the patient is immunocompetent, if it is a small lesion, if it is located in the periphery, usually it is affecting the macula, but if it is at the periphery with very little exudation that you see, observation can be done. Whereas if the inflammation worsens, which the patient will come to you, so the clinical symptoms in this patient would be pain, diminution of vision, floaters, blurring of vision. If the inflammation worsens, then these symptoms are also going to worsen. Or if certain complications start developing, for example, if the patient has serious retinal detachment, then you have to treat regardless of any clinical features that may be present. So how do you treat? Once you decide that this patient requires treatment, you give a combination of antiparasitic agent and a steroid. The antiparasitic basically takes care of the parasite, whereas the steroid will reduce the accompanying inflammation. The body is trying to destroy the parasite. It is just sending inflammatory cells, but it is unable to destroy the parasite because of very often it is a bradyzoid or a cyst form. So which antiparasitic agents do we use? Commonly, under the triple regimen, the classical triple regimen that we utilize, we give sulfadiazine plus pyrimethamine plus prednisolone. The dosages are as shown in the slide. One addition to pyrimethamine that always needs to be made is folinic acid. So this is to prevent any bone marrow suppression due to the pyrimethamine that we are using. In case the patient is pregnant and a prophylaxis needs to be given to prevent congenital toxoplasmosis, then sulfadiazine and pyrimethamine cannot be used due to potential teratogenic effects. So we utilize Spiramycin. Spiramycin is considered to be the safest drug that we can use for toxoplasmosis in pregnancy. This treatment needs to continue for 5 to 6 weeks because it is a very chronic disease. It requires a chronic therapy as well. I will leave a description of the drugs that we utilize in the description box below. Please make sure to check it if you're interested. And steroids, we need to take care to start after the antiparasitic agents and tapered before finishing the antiparasitic agent. At no point are steroids to be left alone because they will worsen the inflammation, they will worsen the disease, and you could have potentially disastrous consequences on the human eye. So how do you know that the disease is resolving? How do you know that now toxoplasmosis is reducing? So you look for centripetal pattern. When I say centripetal, it means first the periphery of the cyst or the bradyzoid, the tachyzoid or the lesion, whatever toxoplasmosis lesion is present on the retina, the periphery of that starts showing a scarring or sort of a healing pattern. Then slowly it progresses to the center. So if you can see, the red arrow points to the peripheral pigmentation. So it means now scarring has started. The central part still shows some whitish lesion. So now that is going to undergo healing over a period of time. Certain newer modalities are also utilized, such as intravitreal injections of Clindamycin plus dexamethasone, still in an experimental stage, given in case there is an allergy to oral drugs such as Spiramycin or pyrimethamine, are not very preferred because they carry their own risks. However, in case oral drugs cannot be tolerated, then intravitreal injections are preferred. Laser or cryotherapy has also been suggested as a modality of treatment. And pars plana vitrectomy. So pars plana vitrectomy becomes basically a surgical line of management. So when would you do that? Treatments that are not responding to medical line or injections, those cases might require pars plana vitrectomy. And it can also help to manage complications. So for example, if there is a retinal detachment, if there is an epiretinal membrane that is formed, which is one of the complications as I mentioned, then pars plana vitrectomy comes in handy. And finally, you need to treat the complications that form epiretinal membrane or retinal detachment, or more commonly cataract. So when you have vitritis, then cataract most likely will happen because vitreous is also responsible for the nutrition of the lens. Secondary prophylaxis is given to reduce recurrence of the disease. As you can see, it is a very chronic disease. Recurrences are very common. So to prevent recurrence, trimethoprim plus sulfamethoxazole is utilized. These are alternate day dosing, and treatment may require to be continued for at least a period of 1 year. So you need to balance the risk benefit ratio. You need to see how risky is the drug to the patient in terms of adverse drug reactions as against the risk of recurrence of the disease. Almost 2/3 of the patients will show at least one recurrence throughout their lifetime. So a very chronic course of the disease, frequent follow-ups are required, maybe even weekly follow-ups may be required for active cases. And recurrences are more common in a congenital toxoplasmosis because the immune system was immature. It was more likely that more organisms are now occupying the retina. So recurrences become more common. That takes care of ocular toxoplasmosis. One quick announcement that I would like to make. We'll be coming live on this Sunday. That is, just let me check the date. That is 26th of July. We would most likely come on Google Meet between 8 p.m. to 9 p.m. The details of that will be shared via your WhatsApp group and the Instagram page. Make sure to check it out. Please keep yourself free around that time. I would like to solve any doubts, any queries that you might have in ophthalmology or otherwise. Just get in touch with you. I've been missing the live interaction with students for a very long time now, and I wish to get back into it. So looking forward to your participation. Please let me know any suggestions you'd like. As always, thanks for watching. Stay safe. Good day.